Can you hear me okay, Dr. Penance?
Yes, for
Yes,
me
we
it's
can.
okay.
Great. I enjoyed listening to Rahul's talk, and I'm glad he got all the hard questions, and that I won't get those hard questions. So that was great, Rahul. So this is a topic. It's quite interesting. I gave this topic in Toronto a couple of weeks ago at AATS, and it was a very similar topic of what do you do between the repair, the replacement, and surgery, and so. I'll kind of go through a little bit what we talked about in Toronto, and I think it's very appropriate now with these two technologies and the two previous talks that have just been given. So these are my disclosures, and for this specific topic, I'm one of the national PIs of TriSend 2 that you just heard Rahul present some phenomenal data on, and I'm on the steering committee of TriLuminate, and I'm a surgeon by trade. So that's why access to all three of these technologies kind of becomes interesting for me and how to deal with this. So this is something that we discuss. I would say we have a valve clinic here at Piedmont in Atlanta where we have 3 structural cardiologists and we have 2, soon to be 3 cardiac surgeons all do most of the valve procedures. And we see all these patients on Monday. And I would say that about a third of we see about 40 patients every Monday. About a third of those are for tricuspid regurgitation. And so all of these are discussed with a surgeon and a cardiologist at the same time in the 11 exam rooms that we have. And so here you can see that I'm going to go through 3 different cases of patients that have come through the clinic, and I'll tell you about how I dealt with the heart team, how I dealt with all 3 of these patients, and we'll go through it not as much in detail in data, but in the decision making that we have. So here's a 49-year-old patient who shows up with symptomatic TR, N3 class 3 heart failure, has some CAD, has had a previous MI, had a stent put in, is a smoker, actually had a right and left stent, I think. He had former smoker, has stage 3 CKD, is on Lasix twice a day, has an EF of about 35%, and had previously an FMR, severe FMR for which they received a clip and had residual mitral regurgitation as part of that clip. And here you can see the tricuspid regurgitation on transthoracic. You can see you don't see very much, but you see some level of tricuspid regurgitation that you have there. And there you can see on the right side of the screen the LV and the mitral clip in position there. We took this patient for a transesophageal, and you can see that the TR has really blossomed on the bottom left-hand corner. You can see that also, and I'll show you the mitral valve in a second, but you can see that there's a lot of tricuspid regurgitation in this patient. Remember, the patient's young, but by the previous physicians who saw the patient, they thought that he was better with a clip, and so this is kind of the patient that I'm seeing now for the first time. And what are our options for this patient? Is it medical therapy? Do we operate on this patient? Do we do a tricuspid valve repair that you've heard about 2 lectures ago? Or do we go what Rahul said, and we do a replacement in this patient? Well, I think that just to remind everybody, the primary reasons for tricuspid regurgitation are about 5 to 10%. Secondary is about 80%, and that's where surgeons come into play a little bit. And then the CIED related about 10 to 15%. What do the guidelines tell us, at least the U.S. U.S. guidelines? They tell us that diuretics can be helpful. That's a class 2A recommendation for medical therapy for TR. And again, a 2A in severe secondary TR, and you treat the primary cause of the heart failure is really what they recommend. And when you look at surgery, it's really class 1 for those patients who have severe TR and undergoing left-sided valve surgery, and it's a 2A for those who have progressive TR undergoing left-sided valve surgery. And really, you can see that there's a cutoff for annulus, as we as surgeons know, and then also right-sided symptoms. There's no class 1 recommendation for isolated TR whatsoever. As you can see, it's a 2A, and so that's really where we stand as surgeons as far as isolated tricuspid regurgitation. And again, a second bullet is 2B for those for isolated TR. For surgery, it's a 2B in asymptomatic patients and a 2B for reoperation with isolated tricuspid valve. The first thing that we wanted to know was what's going on with the mitral regurgitation. And here you can see that you have 2 jets. The left atrium is large, as you can imagine. And this patient because of the mitral regurgitation, we started to think into the pathways of the guidelines, and we did not think this patient was best suited with that much mitral regurgitation. And I ended up operating on this patient. I did a tricuspid valve repair with an MC3 ring. You can see there's no residual tricuspid regurgitation. There's a 31 Magni Ease is what I use. I ended up doing a coronary bypass on him too for his LAD actually. And then a month ago, this is a month after his surgery, postoperatively, he has good recovery of his left ventricle, and right ventricle looks good. He has no more valvular issues left whatsoever. And there's surgical repairs that are common for tricuspid regurgitation, more for the cardiologist in the room. The most common is ring annuloplasty. I personally have not been a huge fan of DeVegas, and so I don't do those. And I don't do the K or the Clover for the most part. I mainly do ring annuloplasties for these patients. Historically, we as surgeons have noted that we've had a 30-day mortality of about, an in-hospital mortality of about 9%. And that's the numbers that have been used for surgical tricuspid valve repair. We have more recently done an analysis in the STS database. I presented this in January of 2024. And what we were able to show is that roughly 2,200 patients are done a year for isolated tricuspid valve repair or replacement. About 2,000 are done in the United States a year for the STS database. And what we've noticed is that there's a mortality of about 5.5%, 5-6%, and not the historic 9 to 10%. Remember, that was in-hospital mortality. This is 30-day mortality. So we're showing much better outcomes across the board for this. And as you can see, this is all the numbers going in a positive direction, that over from 2017 to 2022, we've really made a lot of progress from the close to 8 to 10% mortality all the way down to 5.5% mortality. And you can see that this is prolonged length of stay, it's M&M, it's prolonged ventilation, all of that is much better off. This has just been published in the Annals of Thoracic Surgery in May of 2024. So you've had a good look at some of the catheter options. We're not going to go through those in details because you've heard quite about them. But let's talk about what are some other options that we have, and in our heart team, how we make these discussions. Here's a 73-year-old patient with severe TR. You can see on the echocardiogram, patient had a previous severe AS and had a transcatheter valve put in for that at that time. The patient's EF, also patients in HFrEF. The patient has some mild coronary disease, is a renal transplant patient that actually has failed and now is back on hemodialysis and also has cirrhosis. So you can see that the patient originally, when we saw the patient, the original EF was 20 to 25%. The patient had severe AS, severe TR, on hemodialysis and on cirrhosis. And my personal feeling is that these patients can be operated on, but they don't do very well. And in this patient, what we elected to do was do first a TAVR on this patient to see what would happen. You can see the EF has improved from 35 to 40%. The patient remained on Bumix, but still had severe tricuspid regurgitation. So at this patient, is most likely a pacemaker lead associated tricuspid regurgitation. And you would ask yourself, what would be your options for this patient? And so when we went through the heart team, we thought this is also before the era of EVOQUE, but here you can see the stents that are in the patient. You can see the TAVR valve that's already in place, and we chose to do a TriClip for this patient. A lot of this had to do with his lead placement that he had, but also I think that we probably now would have considered him for EVOQUE because he has good leaflet coaptation, and it would be something that we would think about for him. And here you can see we're able to put a TriClip onto the leaflets for this patient, and we've made some impact for this patient, but he still has, as Mike Mack mentioned earlier, he still has some residual tricuspid regurgitation. A second clip was added for this patient. This is done off-label, actually, at this time. When we were doing this patient was not part of the TRILUMINATE trial, but you can see we've made a dent in his tricuspid regurgitation as we see it. And here you can see that you now have two TriClips, and here you can see the mitral sheath, and there you can see ice. And one of the ways that we've gotten, I know that Rahul mentioned this, one of the ways we've gotten out of imaging issues, especially with pacemaker leads, is with the use of intracardiac echocardiography, which is used very frequently in our cases for this. And so after 2 clips, you go from torrential tricuspid regurgitation to moderate regurgitation. And so at this point with the medications, we believe that this patient actually symptomatically has felt great, but we still left him with a moderate regurgitation. You've already seen the data for the tricuspid clip. I won't show you very much, except to say that there are 2 devices. One is in trials, the Pascal Edwards device, and one, of course, that has just been FDA approved. And as Mike Mack said, and you heard earlier, about 60% of patients had none, mild, moderate. We would fall into that moderate category for this patient. And you can see another about 40% have not been benefited extensively as far as the clip goes. And here you can see the class TR EFS shows a little bit higher numbers, but of course the numbers are small and is still experience that's being gained with this. I think there are a lot of challenges with the leaflet devices. Imaging is a huge one. Catheter navigation difficulties. The regurgitant orifice is often broad and not circular and difficult to deal with. And I agree with Rahul that a transcatheter ring is really the next step to making this better. I did, want to mention that what are some of the failure points we stay away from. I think one of them is the coaptation gap. If you have a coaptation gap of less than 7 millimeters, you can see the moderate or less TR 73%. I'm happier with that number. As you can see with greater than 10 millimeter gap, you only have a 59% success. I'm not sure those should even be attempted with a TriClip. The amount of tethering is really important, as is a different type of a tricuspid valve morphology. So I think we need to start getting more sophisticated in our analysis of who's going to have success and with a clip versus replacement versus surgery. The last patient I want to present to you is a patient. What do we do with this absolutely torrential TR? You've heard some good talks already about this, but here's an 89-year-old lady that we had who had weeping edema of her legs. She had a hypertension, hyperlipidemia. She had a previous RCA PCI. She has some macular degeneration, and she's already on torsemide at 40 milligrams twice a day and metalazone also. I, as a surgeon, am not going to operate on this patient. I think that her outcome surgically would be poor, especially at the age and her macular degeneration and other comorbidities that she has. For this patient, we did not think that TriClip was available. And we thought that Evoque would be the best option. You can see somebody asked the question, Dr. Panos, I think about leads. You can see this patient has 2 leads in place. And here we're able to, because of the laxity and the leads, we're able to drive an Evoque valve into it. I think we've done about 45 of these. And in the trial, we're the 4th largest enrollers for this trial. So a lot of experience with the Evoque valve. And here you can see we've driven this across the tricuspid valve. You can see the nose cone is in the right ventricular apex, is very well seated there. And we're slowly over time. Also, you can see the right coronary stent there, so that gives us a good marker. And here you can see we're now opening up the right ventricular portion of the stent frame. We're almost finished with that component of it. And as we start to unravel and pull back the sheath further, you can see that we're almost completely have finished the right ventricular portion here. There's no need for pacing. There's no need for any of that type of stuff for this procedure. And here we're about to deploy the valve. And I think that this becomes a relatively, in our hands, we've been fortunate that it's been a relatively safe procedure, even though Dr. Mack has obviously noted some of the shortcomings of some of the complications that can occur. Here you can see a fully deployed valve. I think what's important for everyone to understand that the imaging is really intense. The NPRs that you have to understand in 3 dimensions how this works is really important. And I think for surgeons and cardiologists, this is quite honestly unfamiliar territory. In the last 2 to 3 years, I know Rahul and I have spent a lot of time in the cath lab with these patients, and I think we're starting to grasp some of the ideas of really how complex this is, but how we can do it effectively. And here you can see how nicely with this NPR we're able to scan and actually look at each of the anchors as they're being deployed and making sure that we're adequately catching them in this very complex valve, sometimes a quadracusp valve. As you all know, the tricuspid is very complex and is very difficult to understand at times. And here again, different ways of looking at it for this patient that we also performed in Evoque. For that patient I spoke about, a 1-month post-op, she has no more tricuspid regurgitation. Her quote was, "I have not seen legs this small in years," of course, because she used to have weeping legs from that. Rahul showed you this slide as far as the Evoke goes. I'll skip over it. This is what it looks like. I don't remember Rahul showing this. This is what the device looks like, and you have plenty of time. And there are a lot of ways. What makes it easy about this valve is you can move it septal, lateral, anterior, posterior, into the RV, out of the RV very easily. And so the manipulation of the knobs looks overbearing, but it's actually not, pretty straightforward. Rahul showed you this. The results show almost all of the patients have a resolution of their tricuspid regurgitation. There are challenges with the TTVR, annulus size, conduction system, RV function. I've had one patient who had RV failure after this has occurred, and they did not have a good outcome. I think from the over aggressive sizing that we had for that patient. Leaflet thrombosis we've talked about, and we have no clue what the durability is in these patients. So it's unclear when to treat these patients. And I think at the end of the day, when I look at repair replacement, we need to look at hemodynamics, we need to look at implantability, the durability, the thrombogenesis, and the lifetime management. And these are all 5 criteria that we need to look at for surgery, for catheters, and for replacement. We need to decide on what's considered success. Is it the symptoms of heart failure, or is it mortality? We're still deciding on our own what is considered success in these patients. There are a lot of competing risks in these elderly patients that may mask these benefits, and long-term follow-up is required to show the benefit. So I think that it's very important to have a willingness to fail. We've failed, but we've also learned from our early experiences. Rahul mentioned we're continuing to make device iterations. I think there has been an absolute imaging revolution, and I think that there has to be an evolution of the heart failure team, or the heart team, which has to involve heart failure and pulmonary hypertension experts and imagers for the tricuspid valve, people that we haven't used as much in the past, especially the pulmonary hypertension and the imagers. So this is our pathway for Piedmont Heart Institute. We did 75 TMVR and TTVRs last year, so a large volume of these patients. And the way we think of TR is they all need to be on GDMT. Some of them require surgery. When we go into catheters, what we have available at our institution is the TriClip, the Pascal, and the Cardioband. Those are all catheter-paced. And then for replacement, we have Evoke, Trisol. We've done 5 out of the 10 Trisols in the United States. The Croy valves, the Intrepid, the Laplace, and the Heterotopic. And so when we sit with our patients in the room, we actually map out all of these trials, and we try to determine which pathway they're going to go into. So in summary, surgery is improving. It has improving outcomes, and it's been done now with excellent outcomes. The TTVR is extremely safe, but has less efficacy. The TTV replacement has higher morbidity with first-generation devices, but it eliminates the TR in most cases. The ongoing trials show quality of life benefit, but not mortality at 1 year. And I think there's still long-term issues that need to be investigated. Thank you very much.
Thank you, Dr. Tourani, for this excellent and comprehensive presentation. Do it from the moderators.
Yeah.
Any questions?
Actually, sorry, Mihaly. Okay, thank you very much. Excellent talk, Dr. Tourani. Very, very good. I think that the problem is the right heart failure here, and the heart failure generally. We have to select patients that, are suitable for even going to the surgery or for the TTR or for another method. We actually had a patient with heart failure, 20 ejection fraction, that had right heart failure also with huge tricuspid regurgitation. And we didn't know what to do with him because he had all the symptoms of the right heart failure. And, finally we decided, even though that we had all these methods, for example, to go to a TTR with a minimal invasive method, but finally we sent it to the surgeon, and he's right now good. I think that we have to specialize and to see every person differently and every patient differently, because we have a lot of things to think about all these patients. It's not only the technique, which technique is better or not. It's not only the durability of the devices that we have or the effect that the device will have on the patient. We have to think about patient's life and how he will go on. Thank you very much. It was just a comment. There is no question. Yeah.
No, I think that you're absolutely right. Now, I do want to make a comment on how we deal with these patients. And so over the years for these patients, we'll actually bring them to the ICU commonly for the patients you're talking about. We'll put a swan in them. We'll put them on Milrinol. We'll repeat their echo and see what really, we call it prehab. And I think that that's been a term that we've been using quite a bit. And I think that's what's led to some of the outcomes and benefits and outcomes across the board. And for us, you're right. In our program, surgeons and cardiologists are in the valve clinic together, so we see the patient at the same time, and that's why we can make these decisions. After we see them, we then have a separate call on Friday. It's a virtual call for 1.5 hours every Friday morning from 7 to 8:30, where we look at all their imaging and their scanning and stuff, and then we make the final decision. So it has to be together, and we do some of the hard. Surgeons have to put their pants on and do some of these hard cases that we normally wouldn't do. But then we're also very good about sending some of these to TriClip or TTV replacement. So it's a huge team effort, and I totally agree with you on the management schema has to change. It's funny, I'll be in Athens next week. I'm sorry I'm not there today. I'll be coming to Athens for the ICMIX meeting. First Santorini, then Athens. So I'm sorry I'm not there in person.
Can I quick a question about your experience with Cardioband? I saw you doing research on.
Yeah, we haven't. We have not started. We're in the process. We're looking for patients for that, and so we're part of that trial. And it's now getting it's IRB approved for our site, so we're screening patients for it. So we have not had actual experience, but that's now up and running. So we're screening patients. That slide I showed you was from last week, and so we're starting to screen patients for that. We have, I know you asked in the last question, Rahul had not done experiences. I've done 2 cases with IVC devices, and the patient's symptoms absolutely go away. I think Dr. Penos mentioned that also. The symptoms for the patient went away. The patient's mortality, they didn't die, but there's stent fractures that occurred in that IVC graft, and Edwards actually has stopped that program completely. So there's still, I think there's symptom relief, but I'm not sure there's no benefit to the RV at this time.
Dr. Mack, yes.
Thank you very much.
Vino,
Dr. Samar Gandhi is out. Yes, Dr. Mack, excuse me.
Vino, it's Mike.
Go ahead, please.
Great talk. So let me ask you this. What do you think the role of surgery, if any, is going to be going forward? And I know you, as well as us, have experienced about triple the increase in tricuspid surgery, isolated tricuspid surgery volume due to the screen failures for all the trials. And I think it was you that published that surgery outcomes are actually much better now, and the volumes are much higher than we thought before. So do you think that surgery is going to have a significant role going forward? And if so, how are you going to sort that out?
So, Mike, I think that's an important question. And I think that, I'll give you, yes, our tricuspid surgical volume has increased for me quite a bit because of our heart team. The way that we do our heart team, surgeons and cardiologists are physically there seeing the patients together. So we have a complete buy-in to that. And I spend that energy in seeing these patients with the cardiologist. So I think for us, a surgeon is critical to that decision-making on what we're going to do. And the surgeon is also involved in the procedures. I'm less involved personally in the TriClips because that day is my surgery day. And so it's hard for me. And if I can, I try to go in there, but we're less involved in the TriClips. We've been involved in all the tricuspid valve replacements, partly because we understand the mechanisms very well as a surgeon. We see the valve just like mitral valve. And because of the potential complications that can occur, we have also always been there for bailout, for vascular reasons, and for pericardial effusions and all the other things that can happen. So I think a surgeon, quite honestly, is critical to this. We have now done over 45 evokes, so it's one of the world's largest experiences with evoke, and having a surgeon there, our outcomes have been unbelievable, and I think that's partly to do with just the mentality of a surgeon and a cardiologist working together to make sure that we're seeing everything appropriately. So Mike, I hope that the country and the world can follow examples of yours and our program where we're doing a radical number of these cases. We've done 7 evokes in the last 2 weeks, just FYI. And it's something that is working well, but it works well when you have a team effort, not individual people trying to make the procedure work.
Very good. So shall we proceed with Dr. Samargandi?
Thanks, everybody.
Thank you very much.